Okay. Good afternoon, everyone. Welcome you all to 8th Dr. L.K. Bhutani Oration, one of the prestigious oration organized by Department of Dermatology and Venereology of AIIMS, New Delhi. This is 8th Dr. L.K. Bhutani Oration. So to begin the proceeding, I request our Honorable Director, Dean Academic and Dean Research to formally welcome the orator of the day, Dr. Sanjeev Handa, who is Professor and Head Department of Dermatology, Venereology and Leprology from PGIMER, Chandigarh. Please. To take the proceedings further, I request Professor K.K. Verma, Head of the Department of Dermatology and Venereology of AIIMS, New Delhi, to introduce the oration and the speaker. Please.
Thank you. Good afternoon, ladies and gentlemen. It's my pleasure and honor to introduce the oration. As you know, this oration has been instituted in the name of Professor L.K. Bhutani by the institute. We all know Professor Bhutani quite well because he is one of our most talked about, admired, and the respected teacher who has headed the Department of Dermatology and Venereology at the All India Institute of Medical Sciences for a very long time, I think over 2 decades. And then he unexpectedly, suddenly died in July 2004. Dr. Bhutani was born in undivided Punjab in 1936. He studied medicine at Amritsar Medical College and then moved to AIIMS soon after it was founded. He wanted to become a cardiologist, but he landed up in dermatology for the good and betterment of dermatology. He succeeded Professor K.C. Kandhari and became professor and head of the department in 1979. And that was the year when I also entered, incidentally, the institute to join my MBBS course here. But what I came to know that, yes, he was heading the department even much earlier than that. As assistant professor also, I think probably 1974 or 1975 started heading the department when Professor Kandhari superannuated. Dr. Bhutani is known for many things in his career, but he is known for his teaching abilities. He is admired by the students, his research, and also the writing. He was the president of Indian Association of Dermatologists, Venereologists, and Leprologists in 1981 and 82. And also the honorary physician to the President of India from 1983 to 87. He loved traveling, and I had the honor of traveling with him on some occasions. No matter what is the mode of transport, he would love to travel by, say, car, he will love to travel by train, and of course, he traveled globally to attend conferences, giving lectures. And most importantly, he was the Indian face of dermatology internationally. So when you go to an international meeting, he would, the people who would refer, anybody in the country, they would refer by his name that, yes, do you know Dr. Bhutani? Or have you met Dr. Bhutani? When you say that, yes, what an honor and pleasure it is that, yes, you have been taught by him or you have been associated with him. He was a gifted teacher and was recognized for his teaching abilities by Dr. B.C. Rai Award for Excellence in Teaching in 1980. He was an advisor to the World Health Organization. But the most important, what he also considered, and we also know the crowning glory, what we call was the International Conference of Dermatology, which was first time held in India in 1994, which he chaired. And in fact, he brought the Congress to India. Otherwise, it wouldn't have been possible. As I said, he was a keen researcher. He has several publications and was a prolific writer. He has been on editorial board of several journals. And very often when we used to turn around and look at the journals, we will find him. And most referred were the seminars in dermatology that time, the very popular, say, the literature in dermatology field. And of course, we know that, yes, the very famous color atlas of dermatology and the color atlas of sexually transmitted diseases, which are still internationally acclaimed. Dr. Bhutani was said to be the quintessential Englishman, well-dressed all the times, well-mannered, and well-spoken. One of our director often used to call him, "Where is our Englishman?" And then he used to come and say, "No, I am very much Indian." And the second very, say, important, and he was very fond of cycling. Most of the times he will cycle from the home to the office, and then we'll park the cycle in the fire. So we were sometimes wondering that, yes, nobody takes away the cycle. We invite real intellectuals to deliver the oration on the subject of their choice. And the past orations were delivered by very eminent personalities like Dr. Guleria, the senior Guleria, Professor J.S. Guleria, Dr. J.N. Pandey, Dr. Sanjay Agarwal, Dr. Srinivas, the other Srinivas, C.R. Srinivas, and some other very eminent people. But this year we have invited the equally eminent speaker, Dr. Sanjeev Handa, who is professor and head of the Department of Dermatology at PGI Chandigarh, a very close friend and dear friend of mine, who will deliver the oration on the topic, My Tryst with Contact Dermatitis, which was the area which was quite far off from Dr. Bhutani. He loved different areas like leprosy, sexually transmitted infections, the pigmentary disorders, and several others. So it's my honor now to introduce the speaker also. Dr. Sanjeev Handa, as I said, he is the professor and head of the Department of Dermatology at PGI Chandigarh. He did his medical graduation from Government Medical College, Patiala, Punjab, and then MD Dermatology from PGI itself. And then he moved on to join the faculty. He is very well known in the dermatology community for his teaching, for his research abilities, and also for the patient care. He has more than 300 publications to his credit, and he is a fellow of National Science Academy. He is also the fellow of Royal College of Physicians and also the American Academy of Dermatology. He has numerous awards. He also got Dr. L.K. Bhutani Award for Excellence in Teaching from the IADVL, which is Indian Association of Dermatologists, in year 2015. And then there are many. I don't need to name them. And he is also associated with several professional bodies. And very recently, he has been inducted as a member of the International Contact Dermatitis Research Group, the coveted international organization in the field of contact dermatitis. So it's my pleasure to invite Dr. Sanjeev Handa for the oration. Sanjeev, over to you.
Thank you, Dr. Kaushal, for that introduction. I would like to take this opportunity to, first of all, thank the academic section of AIIMS, New Delhi, which considered me worthy to deliver this oration today. I would like to take this opportunity to thank the director, AIIMS, Dr. Srinivas, the Dean Academics, Dr. Meenu Bajpai, the Dean Research and Head of Dermatology, Dr. Kaushal Verma, Dr. Mrs. Manorma Bhutani, her family, my dear colleagues. It's a pleasure for me to be here with you all today evening. This pleasure is because of two reasons. One, because I have been bestowed with this oration, yes, but another because there is a personal connect to this oration, and that is that I am a second generation dermatologist and my father was a personal friend of Dr. L.K. Bhutani. My father headed the department of dermatology at GMC Patiala, and then he retired as the Director Research Medical Education Punjab. Before I begin, let me acknowledge that I am indebted to my institute, PGIMER Chandigarh, which has given me the platform to be where I am today. Without the backing of the institution, my colleagues, my students, and of course the patients, you cannot carry out any research. So wherever I am today, I owe it to all of them put together.
Professor Handa, we'll just take excuse from you. We were conducting an interview and we would have the privilege of hearing your oration, which is being recorded.
Thank
so
you
Director and I will take leave of you.
Thank you
very much. And sorry about it.
Thank you. We heard about the introduction made by Dr. Kaushal Verma of Dr. Bhutani. Many of you have known him personally, but let me tell you that though diminutive in physical stature, he was a towering persona as head of the Department of Dermatology and Venereology at AIIMS, and then as director of this institution. And one more thing which many of you may not know is that he was the first Honorary General Secretary of IIDVL. I know this because those were the days when all close friends were also dermatologists and associated with IIDVL in some way or the other. And I remember my father writing letters by name. Those days, they did not have mobiles, and they would actually write letters to each other. And that is how I was very familiar with this name, even when I was a young boy in college. Dr. Bhutani, as already told, has been known for his work in treatment and containment of sexually transmitted diseases and HIV/AIDS. He was also involved in the management of leprosy. But what I remember from dermatology when I was a student was his work in lichen planus pigmentosus, which was published when we were beginning our careers in dermatology. And I think that was one of his landmark works in general dermatology, which is quoted till today in standard textbooks of dermatology. I would like to dedicate this oration to my father, Dr. Surinder Kaur, my ex-head of the department. She is no more with us today, and late Dr. S.C. Sharma, who initiated me into contact dermatitis and was also my thesis guide. For those of you who do not know what I did when I was a student like the postgraduates here, my thesis was on contact eczema, and I worked in that area ever since. So I would suggest to many of the young people sitting here that your thesis topic should be chosen with passion and with that interest that you can carry it onwards all through your life. And I would also like to dedicate this thesis to all my patients and my students who have been a part of many of my projects. Whether I am able to acknowledge them here or not, I think I would not have been able to do this work without their support. My first publication, can I have the presentation on, please? My first publication in contact dermatitis was on footwear dermatitis, I told you, and that is when the story began, or the love affair began, and then it went on and has continued till date. I have worked in diverse areas of contact dermatitis. And today I have summed up for you some of my presentations in these areas: on epidemiology of the disease, on clinical features of the disease, on allergens and patch testing, on different clinical presentations, whether it is footwear, implant related, dyes, cosmetics, hand eczema, or related to therapy. I'll begin with a few presentations in epidemiology. This is not in chronological order, just for convenience. The initial work that we did on epidemiology was to find out what sort of patients do we encounter in our contact dermatitis clinic in North India. It is not that this was a landmark work, except for being probably one of the important studies from North India. There are other regional studies also in India. We had this as a group of around 560 patients, and what came across is true probably even today. That is airborne contact dermatitis, which was a substantial chunk of our patients in the contact dermatitis clinic. And patch test rates were positive to the tune of around 63%. And what is surprising even for today is that the type of patch test results that we encountered then, this study was in 2011. So I'm talking about something like maybe, if you can say 30 years or 30 years plus, that the patch test allergens which come out positive probably remain the same, have been unchanged for 30 years. We still have nickel and potassium dichromate topping the list as we found way back in 2011, along with parthenium. So this means that probably that work is still relevant today as it was then. Then we also worked on the epidemiology of topical corticosteroid sensitivity. And we had results in around 100 consecutive patients that we took for managing leg ulcers, stasis dermatitis, perianal dermatitis, hand and feet dermatitis, areas where we commonly use topical corticosteroids or patients have used corticosteroids prescribed by private practitioners. And we had positivity rates of around 2%. And I was surprised to read the other day, just a couple of days back, a Danish study on corticosteroids, which said that there is a positivity rate of around 2.7% in those countries as well. And our result at that time made us think that tixocortol should be included in the Indian standard series. I am sad that we have not been able to do till today. This study was in 2016. So I would say that we are behind what our findings were and what should have dictated our patch test series today, because this is a very important component of managing patients who have contact sensitivity to topical corticosteroids. Then we did some more work on airborne contact dermatitis, looking at its etiopathogenesis and management, and we had figures to the tune of 40% of patients attending contact dermatitis clinic. I think those of you who are actively involved in managing these patients would know that that is a figure probably more or less true of even today. And this study was published by us way back in 2011. And the most common allergen at that time was Parthenium hysterophorus. Then in clinical presentations, this is one of my first case reports as a young faculty who had just started publishing in his own name. And I take immense pride in that this case report, if you notice, is in black and white, because at that time, IJDVL used to publish black and white figures. But I was emotionally attached with this paper and I wanted to put it up here. This was granulomatous contact dermatitis to nail polish. The lady came to me in my OPD, showing me both the dorsa of her hands. And if you can make out at the middle of the dorsa of her hands, there are small papules in a figure 8 pattern. We didn't have too much of access to patch test kits as in Cosmetic series today at those times. So we were left wondering what are we dealing with. And this paper we talked about, because at that time the awareness was about zirconium-based granulomas. So in this study we talked about zirconium-based granuloma-like reactions induced by nail polish. We were thinking it could have been because of toluene formaldehyde-based resins, but we were not sure. Then there was another interesting case that we had, a patient with localized erythema multiforme from laundry bar soap. This made me jump that, okay, we have seen many patients of contact eczema, but we do not see erythema multiforme that commonly. And I think that is true even today. We do not see erythema multiforme. It's been reported in the textbooks, yes, but it's uncommon. And this patient had developed it to laundry bar. You would remember, if some of you know the name, Nirol and Rin. He had used 2 of those bars and he had developed this sort of a presentation. And he was patch test positive with those solutions. Then another interesting case, which I thought I must highlight here, that we did and which we felt should make all our colleagues all across the country aware, was eczema herpeticum complicating Parthenium dermatitis. Now, this can be an emergency if the dermatitis itself is extensive. If it is extensive and you have eczema herpeticum coming up on top of that, it can be a dangerous situation and you can lose a patient. This patient did well with acyclovir. This was at that time a study highlighting the importance of being able to find eczema herpeticum on top of an eczematous rash. Then we had another interesting case where a patient presented with orodynia and she was being managed. This many of you may encounter even today. She was being managed for oral lichen planus with topical anesthetic agents. We often give it in cases of severe lichen planus, saying this will take care of the pain. But mind you that this can be the end result even today. So this is as significant today as it was at that time. And we use a lot of benzocaine for dental procedures, post-dental procedures. We use it for patients of pemphigus when they are unable to eat food. So remember that this may be as true today as it was then when we published it in 2015. And this patient had patch test positivity to benzocaine, paraphenylene, diamine and nickel. And she had a rash all around her lips and on her hands. So both the lips as well as hands with the finger with which she applied that benzocaine was also involved. This was a second patient in the same series. Then we worked on oral mucosal lichenoid lesions and we noticed something which made us think that this probably needs more looking into. That was whether the dental restoration material caused lichenoid lesions or lichen planus-like lesions, if you would like to call it that. And we did find that when you had lesions in close proximity to the amalgam or the restorative substance, that time you probably had more chances of it being true contact positivity. And this we found to the tune of around 44.5% in our 45 patients. And as expected, we had patients positive to mercury, which is a part of the dental amalgam, to nickel and palladium. And patients, when they had this dental restorative material removed, they did very well. Then coming to the allergens and patch testing techniques per se, there was some work that I did of writing a commentary actually on a publication several years back of, if some of you may have read that paper, Chamber X, which was actually low density polyethylene based chambers which were manufactured in Bombay. But I regret till today that in spite of having written that commentary where I had suggested that it should be commercialized, that did not happen. And probably in today's day and age where we have the Prime Minister himself talking about innovation, probably that material and that situation was before its times. Had that happened today, probably we would have seen that actually fructify. So it would have been an original Indian patch test kit. I have not put that paper here because it was a commentary. But anyway, this was in relation to the patch testing and allergens. There was a study we did on commercially available plant allergen series. This was in 2015 again with my colleagues. And the gist of this study was that the allergens which are made through the plant extracts are the best, followed by cis-quercetin lactones when we are testing for Parthenium allergy, and followed by parthenolide. In effect, parthenolide, as it was available in the plant patch test series by Chemotechnic, which is the body making the allergens, was not as effective as expected. Then coming to that publication I was talking about, footwear dermatitis, which resulted from my thesis. This was a collection of 30 patients where we found that rubber chemicals were the commonest allergens, and V chappals, or Hawaii chappals as we call them, the Bata chappals, were one of the commonest cause of causing footwear dermatitis in patients. And there was a recent article which said that that is relevant even till today. And in footwear dermatitis, rubber chemicals still form the most important cause of contact allergy. Then coming to more recent work that we did, hand eczema, all of you know, is something which we encounter day in and day out in our OPDs, and it's a very frustrating problem. Imagine somebody having hand eczema and not being able to do his day-to-day activities, whether personal or professional. And that is what made us work on hand eczema. And we tried to correlate the morphologic patterns with atopy, contact sensitization, and disease severity as well. For this, we recruited 100 patients and we tried to study the patterns involved. We could not find a specific pattern except Pomphylix, which was specific, or hyperkeratotic eczema or fingertip eczema. A large chunk of the patients, I would say, were unclassified. And patch test positivity was high, to the tune of 65% in these group of patients, and we could establish relevance in around 60% of the patients. And the common allergens were potassium dichromate, 25%, which I believe is because most occupational hand eczemas occur in people who work in the construction industry. So that probably explained the patch test positivity in this group of patients. Then fragrance mix, which was a bit of a surprise for us, but we thought that so much of fragrances are encountered by everybody in today's day and age that probably that what accounts for the fragrance positivity. And then nickel and of course PPD, a group or paraphenylene diamine, which is a component of the dyes, which is again so much use even by people as personal hair care products. But we did not find any correlation between patch test positivity and hand eczema severity. Then we looked at another aspect of hand eczema, that was because hand eczema is often associated with atopy. And we got down to thinking that if there is atopy, then these patients may have what we call as filaggrin gene mutations, which are well known to be associated with atopic eczema. And we did a study on these filaggrin gene mutations, and our results were rather surprising even for us. The mutations were seen in close to 33.7% of the cases. And the most common mutation was the S2889X. I will not bore you with details. But anyway, the significant association of filaggrin mutations was with irritant contact dermatitis, both with and without atopy. Explainable, because these filaggrin mutations, those of you who are from dermatology know, they lead on to those natural moisturizing factors and cause that sort of barrier disruption if they are present, that it leads on to more chances of irritant as well as allergic contact dermatitis. So this was a publication which was more recent that we did, that was in 2019. Then we did work on implants. And carrying forward this work, actually the first work which I did was way back in 2003. This was again a patient who got me very excited. A lady came to me, 57 years old, with a knee transplant and a large dermatitic patch on her knee. And the scar there on the knee crossing through the eczematous plaque. And I was wondering now, does she have a metal sensitivity? And in those days, we did not have these implant series, so to say, available to us. So we did something which was at that time available in the institute, in the research setting, that was atomic absorptio spectrometry. So that was done in this patient, and this report was published. This patient did have elevated levels of nickel sulfate in the blood, but we could not say with definite conviction that yes, it was that implant causing, though the serum metal levels were normal. And exact immunological mechanism at that time to us was unclear. But we carried on with this work more recently in 2021, where we decided to look at implants afresh because implants are become that much more common today. We have implants left, right, and center. We have not only orthopedic implants, we have cardiac stents. We have many other implants taking place. And we looked at 54 patients with orthopedic implants, and we decided we will do a pre-implant patch test in them to see whether they had an allergy. And then we'll do a post-implant patch test in them 6 months down the line and see what happened to their allergic status. And we got results which were interesting. New contact sensitivities had developed in 13.8% of the patients. And we used a list of allergens which we made on our own to cut down on the costs, because the implant series otherwise was very expensive with the whole list of allergens as it was. So it was not the best of situations, but that is what we had to make do with. And the results led us to conclude that in an orthopedic implant, in a patient, when you have done a pre-implant testing and no history of metal allergy is there, no testing may be needed. But if you have a history of metal allergy, then patch testing is needed. And that patch testing should be done with not only the baseline metal series, but with extended prosthesis series and bone cement. The reason why I say this is, please understand that if a metal implant goes wrong somewhere in the body, to remove that implant is a very major and serious decision for any patient. If it is the knee, the hip, or the shoulder. And if the post-implant situation was of symptoms, then again patch testing is indicated. But if no symptoms are present, then no testing is needed. So in essence, we can say that a pre-implant positive patch test does not necessarily indicate that the patient will develop clinically significant post-implant complications. But also a patient with pre-implant negative patch test may develop hypersensitivity following implant. That is sure. A post-implant positive patch test in the setting of an implant-related complication may warrant an implant removal. Now that's a very serious decision to be taken by any orthopedic surgeon, and they often look forward to you to advise them whether the implant needs to be taken out as a dermatologist. Then we did some work on the cosmetics and hair dyes. And this we did over the years. The first study that we did was way back in 2000, which we did finding reports of around 59.2% positivity. This work has been done by Dr. Neena Khanna here in this department as well. I have read her reports as well over the years. So I think she will resonate with me on that this figure has been increasing over the times. And recent Indian studies have given figures to the tune of more than 70% positivity with cosmetics. The other issue which we found very interesting was epidemiological trends in contact dermatitis to hair dye. And this, to our mind, was shocking. We saw prevalence to the tune of 4.7% in the year 2000. But then in the year 2010, a decade later, it had gone up 4 times or 4-fold and was to the tune of 16.4%. This made us think that this tells us 2 things actually. That is, one, uncontrolled use of concentrations of PPD in hair care products being available in the market. The second was increased use of hair care products by the general population. So these are 2 carry-home messages which we had from this, resulting or accounting in this type of this, besides the use of a lot of tattoos by using concentrated PPD for making tattoos by children and as those stick-on tattoos on paper, which could lead to sensitization with PPD. So those were very important from a social point of view. Then more recently in 2019 again, continuing our work on hair colors, we worked on a condition known as acquired dermal macular hyperpigmentation. Now, this is in today's day and age been made a dustbin diagnosis for pigmented contact dermatitis, erythema dyschromicum perstans, and probably LPP, and what all occurs on the face or in those areas which are affected by the use of cosmetics. And here also we got interesting results. Patch test positivity to the tune of 36.1%, and patch test positive patients with a higher mean age, symptomatic pigmentation, hair margin involvement, and ill-defined lesions. Then coming to our work in therapy, a couple of papers before I wind up. We did some work on narrowband ultraviolet B. I'm sorry to say that we have not been able to carry on with this work. I think more so because of our, if I may be honest, our UV chambers being utilized by patients of vitiligo and possibly psoriasis and CTCL rather than being used for patients for management of patients of airborne contact dermatitis. We had good results with this. I think those of you who have been using this modality understand that partly the effect is hardening, partly the effect is immunological induction of anti-inflammatory interleukins, partly direct apoptosis or effect on Langerhans cell activities and things like that. Then this was an older study which I did with my colleagues Dr. Sahu and Dr. V.K. Sharma, who was also the head of department here in dermatology. This was oral hyposensitization in patients with contact dermatitis. Very difficult work to carry out actually. Why we discontinued this was because we had to make these extracts on our own, and you can understand the problem in making extracts of Parthenium when you have to collect the plant, then dry it, and then make those extracts out of it. And nobody is willing to cut those plants for you because they all know that it is an allergenic plant and can result in an allergic reaction. So this was work which we didn't carry on. I wonder whether this work can be done with commercially available extracts. I think we will explore this option with the Department of Dermatology here and see if this can be carried on further, because there is a definite role of oral hyposensitization or desensitization in nickel allergic patients. We all know that. Then in treatment, we worked upon methotrexate use and compared it with azathioprine. Azathioprise in allergic contact dermatitis has been explored tremendously by my colleague and friend Dr. Kaushal Verma here in AIIMS, and he has several publications to his credit on that. And we thought that we can probably take up its cheaper cousin methotrexate and see those the toxicity profile of methotrexate is probably a shade worse than azathioprine, if I can say that, though we didn't have that issue in our study, but they both seem to work equally well in so far as clearance of patients is concerned. And lastly, I am looking forward to working with the International Contact Dermatitis Research Group. Happy to share with you that news has been given to you by Dr. Kaushal Verma. He actually gave me that news after his meeting of the ICDRG. So we are now 2 dermatologists with an interest in contact dermatitis in the international body, and I look forward to much more work in this with that organization helping us and holding our hand. Thank you for your patience.
Thank you, sir, for sharing your experience with the presentation on your tryst with contact dermatitis. Now it is time to do the felicitation. So I request Professor K.K. Verma and Dr. Rajiv Kumar to do the honor by felicitating the orator of the day. बोलो Now I request Professor Rajiv Kumar, Associate Dean Academic, to deliver the vote of thanks.
Good evening. On behalf of the All India Institute of Medical Sciences, the academic section, and the Department of Dermatology, Venereology, and Leprology, it's my privilege to thank Professor Sanjeev Handa for accepting our invitation to deliver this oration. Dr. Bhutani has been somebody who all of us who've been undergraduates who've seen him was somebody you would see from far and near. Dr. Bhutani. It's like he would stand out in a crowd. And the typical Englishman that's been said about him is so well known. I mean, for anybody who saw him at any age during that period, he was the most dapper looking person on the campus. And always a Oh, yeah. So we knew about the cigars as well. We knew about the cigars as well. And therefore, I mean, he would be somebody you would see and you would know that this is a gentleman who's standing out, walking and confident. So always a pleasure to see him. He would come and deliver to classes. And always somebody to look up to, somebody you would aspire to look like and behave like. So always a pleasure to have had Dr. Bhutani on the campus at those times. So thank you very much for the oration. Again, the topic that you've delivered is something I think it concerns so many of us who don't even actually care about it on so many occasions, because many people believe it's just happening. It's just there without actually getting involved in getting it treated and getting it evaluated. So thank you very much for agreeing to come and deliver the oration, to the department for organizing it, to members of the academic section and the people within the administration who've helped us organize this oration. Thank you very much, everyone.
Now I request all of you to please join us with a cup of tea outside.